Today, we're diving deep into Sjogren's syndrome. It's a complex, multi-system autoimmune disease that honestly gets misdiagnosed all the time. Our goal here is to really unpack the architecture of this autoimmune attack, from how it shows up in patients all the way down to what's happening at the molecular level. The journey to even getting a name for this condition can be incredibly long and frustrating. Take the story of tennis superstar Venus Williams. Her experience is a perfect example. She went from being at the absolute peak of her sport to struggling with debilitating fatigue and other symptoms for almost a decade before doctors figured out it was Sjogren's. Her story really shines a light on just how challenging this disease is to diagnose. So, here's how we're going to break it all down. First, we'll figure out where Sjogren's fits in the big picture of autoimmunity. Then, we'll look at the two very different ways it can show up. After that, we'll get into the nitty-gritty of the cellular attack, talk about how we can predict how severe it'll get, and finally, we'll cover the most serious risk of all, lymphoma. Okay, first things first. We need to get our bearings. In this huge family of autoimmune inflammatory connective tissue diseases, or CTDs, where exactly does Sjogren's syndrome sit? Well, here's a surprising fact. When you think of the most common systemic autoimmune diseases, you probably think rheumatoid arthritis is number one and then maybe lupus, right? But actually, Sjogren's is number two. It's far more common than many people, even in medicine, realize, which makes understanding it absolutely critical. So at its very core, what is Sjogren's? The technical definition is a lymphocytic exochronopathy. Let's just break that down because it tells you everything. Exochronopathy means there's something wrong with the exocrine glands, the ones that make moisture, like saliva and tears. And lymphocytic, well, that tells you who the attacker is. Lymphocytes, a type of white blood cell. They're supposed to be defending the body, but here they invade these glands, clustering around the ducts and blood vessels and just shut down moisture production. And the demographic profile for Sjogren's is just incredibly specific. It overwhelmingly affects women, with a really striking 9-to-1 female-to-male ratio. And it typically hits in middle age, usually between 40 and 60 years old. Now we get to a really crucial point. Sjogren's isn't a one-size-fits-all disease. It actually has two very distinct faces, or phenotypes, and which one a patient has really determines everything about their clinical course and how serious the disease is. So you can think of the patient population as being split right down the middle, about 50-50. On one side, you have the glandular form. This is what people most associate with Sjogren's, the hallmark sickest symptoms. We're talking severe dry eyes and dry mouth. Then on the other side, you have the extraglandular form, and this is where the autoimmune attack goes systemic, moving beyond the glands to target major organs like the lungs, the kidneys, and the nervous system. This is the version of the disease that can become incredibly severe and even life-threatening. So what's actually driving this? What's going on at the microscopic level that causes all this damage? Let's take a look at the specific immunology and genetics behind this autoimmune assault. You can really boil the pathophysiology down to four key pieces. First, there's a strong genetic link, specifically to something called the HLA-DR3 haplotype. This genetic susceptibility seems to set the stage. Then, you have a tag team assault from both T cells and B cells. The T cells, specifically CD4 plus T cells, swarm the minor salivary glands. At the same time, B cells are infiltrating the major salivary glands, and a major consequence of all this B cell hyperactivity is the creation of the disease's signature autoantibodies, anti-Rho or SSA and anti-LA or SSB. This leads us to a huge clinical challenge. If you know the disease can split into these two very different paths, how can you possibly predict who will stick with just glandular symptoms and who will go on to develop the dangerous systemic form? It turns out there are some key biological markers that help us figure this out. So this is the million-dollar question for any doctor managing a patient with Sjogren's, right? What are the specific red flags in their lab work that scream high risk for developing those severe systemic problems? Well, we've got four major predictors to look for in their blood work. First, low levels of complement proteins, especially C3 and C4. This tells you the immune system is in overdrive. Second, the presence of those anti-Rho and anti-LA autoantibodies we just talked about. Third, a positive rheumatoid factor. And fourth, the presence of something called cryoglobulins. These are proteins that clump up in the cold and signal that the B cells are really starting to multiply. Any of these is a sign of higher risk. Let's just focus on those anti-Rho and anti-LA antibodies for a second, because their importance is huge. Not only do they predict systemic disease and point to an earlier and more severe case, but they're also a major risk factor for B-cell lymphoma. And critically, if a patient with these antibodies becomes pregnant, there's a 2 to 5% risk that those antibodies will cross the placenta and cause a serious condition called congenital heart block in the baby. Okay, so that brings us to the most feared long-term outcome in Sjogren syndrome. It's really the logical and most dangerous conclusion to the chronic immune stimulation we've been talking about. The single biggest long-term danger for a patient with Sjogren's is a massively increased risk of developing a very specific type of cancer, extranodal marginal zone B-cell lymphoma. This cancer grows directly out of that out-of-control chronic B-cell activation that is so central to the disease itself. Because of that risk, knowing the warning signs for this transformation into cancer is absolutely essential. A major red flag is persistent swelling of the parotid glands, especially if it becomes lopsided, painful, or lumpy. Another bad sign is the appearance of purpura, those little purple spots on the skin, which points to underlying inflammation of the blood vessels. And again, those lab markers we mentioned, low C4 and cryoglobulins, are powerful predictors. Seeing any of this should trigger an immediate workup for lymphoma. You know, when you step back, the story of Sjogren's is really a powerful lesson. It shows how a truly complex and dangerous systemic illness can hide for years, sometimes decades, behind symptoms that seem so common, so benign, like just being tired and having dry eyes. It really makes you wonder, doesn't it? How many other complex diseases are we missing just because the first clues seem too ordinary to take seriously?